So now we're on to the digestive system chapter, and after we get done with this chapter, we'll do metabolism because those are two chapters that are connected in most lecture texts, and we'll go ahead and do it that way too. After that, then we'll go ahead and do renal and fluid and electrolyte balance. As far as the digestive system goes, you guys are working on that in lab, and we have two ways that we can subdivide the digestive system, basing them upon whether it is part of the gastrointestinal tract, which is a tube from mouth to anus, and has the following structures associated with this: the oral cavity, the pharynx, the esophagus, the stomach, small intestine, large intestine, and anal canal. And so you'll be doing your evals on your cats, starting at the mouth and finishing up the anus, and you'll then also, as you go down the digestive tract, you will add on the accessory digestive organs, and you'll describe certain things such as the teeth, the tongue, the salivary glands, the liver, the gallbladder, and the pancreas. And so those things are listed up above, and you should be able to fill the information into these two areas on your own. So I'm not going to write them down because we already have them listed up there. But as you fill in your own notes and make sure that you know the structures, it's very nice to actually write it down to help reinforce the memory itself. One thing about the gastrointestinal tract, it has an additional name. It's called the alimentary canal. And what's really interesting about the gastrointestinal tract, or the alimentary canal, it is actually, its lumen is considered outside the body. And that's kind of a strange statement, but you have to realize, if you take a penny, which is outside your body, and you put it in your mouth and give it some time, it will come out the other end. And so things can go in and not be actually manipulated or adulterated in any form. And so it's almost like it's never inside you. And when you think of things inside you, you have to realize that that involves a certain type of invasion into the soft tissues, into the blood vessels. Whenever somebody does a venipuncture, they actually will invade a vein in order to get inside you. And so that's another reason why the alimentary canal or the gastrointestinal tract is considered outside of you, because things from the outside world can be experienced inside, but it's like they were never inside you when they finally come out. The digestive processes that we're going to go over with this chapter are ingestion, propulsion, mechanical digestion, chemical digestion, absorption, and defecation. We won't spend a lot of time on ingestion, which is basically defined as taking food into the mouth, but I will bring your attention to there are certain physical structures you must have in order to be able to successfully take food into the mouth. That you have to have them and they have to be intact. Does anybody have any idea what I'm referring to that may not be intact, therefore making the ability to actually eat or feed a difficult task? Babies don't have teeth. Babies do have a tongue, but you can actually survive without much of a tongue. Lips. Absolutely. Lips and cheeks, as well as your palate, correct? Because if you have a cleft palate, how well do you feed? Not very well. Yeah, it goes up into the nasal cavity and out the nose. So you have to realize ingestion seems rather simple, a simple process to you. But if there is a defect, an anatomical defect, you can indeed have a difficult time getting foodstuffs in to stay in once you actually try to bring them on in. So ingestion does involve the structures related to the actual oral cavity, your lips, your cheeks, as well as your palate, hard palate and soft palate. Propulsion, that's a movement. And so we will move food through the digestive tract via swallowing, from the oral cavity into the esophagus, and then via a process called peristalsis. And peristalsis is a squeezing behind the food bolus action with a relaxation of the muscles in front in order to actually move things. We'll talk a little bit more about that when we get into more of the material. Mechanical digestion versus chemical digestion. So digestion is breaking the material down into smaller particles. And mechanically, when we take food into our mouth, it's in a big wad of material, and we mechanically nosh on it. So we chew on it, whether it's with or without teeth. You know, we use our tongue if we don't have teeth. And so we're physically trying to mash it down into physically smaller pieces to where we get it to a level where chemical digestion can actually be effective. Because chemicals applied to a big surface area will not get into the material very well. And so we want to break it down into itty-bitty pieces where when we apply a chemical to it, we can actually get into it and break it down into the molecular level for absorption into the cells. So with mechanical digestion, let's go ahead and add the mastication is the term for chewing. Churning is a process that will be experienced in the stomach. And segmentation is a process that will be experienced in the small intestine. Segmentation is an interesting process. It's where the small intestine will clamp down on one end, clamp down on the other end, and pretend it has what I call muscular teeth, and in between it will actually contract down on the material inside of it, mushing it around so that it actually breaks it down physically. So mechanical digestion, we want to break the material into smaller pieces. So it's not really something that we can absorb into our bloodstream or our system. Chemical digestion, we will pour acid on the food whenever it gets into our stomach, as well as various enzymes as it travels through the digestive tract. And the enzymes are designed to actually break the material now down into molecular pieces that we can actually absorb. And absorption, transport of digestive materials. So we actually now want to get the foodstuffs actually really into us, not inside the lumen of our alimentary canal, but actually into our bloodstream. So this is moving into blood capillaries plus lymphatic capillaries. And these lymphatic capillaries, we will give them a different name. They're called lacteals. When you hear the word lacteal, what color comes to your mind? How about lactation? White. And indeed, that's what the material looks like. It's actually going to be fatty material. Fatty material has a white color to it, and that is what actually gave rise to the name lacteal. So it was a good guess on the teal story. Defecation, elimination of indigestible components. As that penny traveled through the digestive system, that was expelled through an act of defecation. But indeed, what we cannot absorb, we will remove. And before we remove that, we will eliminate as much water from that material as reasonable for our homeostasis. Let's take a look at the structural plan of the abdominal pelvic cavity. The term peritoneum should automatically make you go to the inside of the abdominal pelvic cavity, because that is what the lining is. It's called the peritoneal lining, and the cavity inside is called the peritoneal cavity. Our notes here say the serous membrane lining the abdominal pelvic cavity, and we know the lining is the parietal peritoneum. And therefore, the serous lining over the organs is called the visceral peritoneum. So the organ has to be within the peritoneal cavity. So there is a small space between the organs and their visceral lining and the peritoneal cavity, and this space has a serous fluid. It's not a large amount, it's a small amount, just like we had in our pleural cavity. And this serous fluid is here for one of the same purposes as the pleural cavity in the aspect that it is designed to decrease friction. Because as material moves down through our alimentary canal or intestinal tract, those innards are going to actually move around, and we want them to move around without any stickage or adhesions, and so that's what that serous fluid is also designed for, to decrease that friction. And I wanted to start there because now I'm going to come to the two terms here, intraperitoneal organs and retroperitoneal organs. Intraperitoneal organs are suspended within the peritoneal cavity, and so they will be surrounded or lined with visceral peritoneum. So suspended within the peritoneal cavity, and the thing that's going to suspend them in the peritoneal cavity is mesentery, and we'll get to that too in just a moment. Retroperitoneal organs, let's look at the definition. Located superficial to the peritoneum. Way back at the beginning of the first semester, we learned some terminology: medial, lateral, proximal, distal, superficial, and what's the other one that is paired with superficial? Deep. And so that's what that's referring to, superficial to the peritoneal cavity. So isn't that outside the peritoneal cavity? And so retroperitoneal organs are not lined with a visceral peritoneum because they are retroperitoneal. They're outside of the peritoneal cavity. And most people, when they hear the term retroperitoneal, retro means behind, right? The past. Well, one of the things I want you to realize, I want you to understand it's superficial to the peritoneal cavity, because there are some organs that are on the anterior aspect of our peritoneal cavity, and for us that's the bladder. And when you dissect out your cats, the problem that you have with the cats is that you think that the human bladder is like the cat bladder. When you opened up the cat's abdominal pelvic cavity, wasn't the bladder like right there? With us, it's retroperitoneal. And so what that means is if you were to take a laparoscope and look inside somebody's abdominal pelvic cavity, you would not see the bladder at all because it is retroperitoneal. Now, when you feel a full bladder, where do you feel it? When it's becoming uncomfortable? Lower aspect of your abdomen, correct? Above the symphysis pubis, that's where the bladder is located. And when it's getting full, it actually, it's a hard little ball, and as it starts to actually distend with fluid, it stretches and stretches and stretches up the anterior aspect of your abdominal wall. It doesn't fall into your abdomen, it actually spreads across that and will, because of the weight, fall a little bit into your abdomen if you're laying on your back. But it is actually not something that you would see if you were actually looking into the abdomen. So it is behind the parietal peritoneum, anything that is retroperitoneal. Organs that I want you to know as being specifically retroperitoneal for us, associated with the digestive system, is the pancreas, the duodenum, and our ascending plus descending colon. So those things are not in the abdominal pelvic cavity. They are retroperitoneal and covered up with the parietal peritoneum. Now, mesentery is going to be what is responsible for keeping being attached to our intraperitoneal organs. And what's important for you to realize, our notes say it's a fused, double-layered section of peritoneum. We all started out like a tube, and our organs fell into the lumen of our tube. So let's go ahead and put a little parietal peritoneal lining inside our tube here. Now let's realize that we had an organ right back there that's going to fall into our peritoneal cavity, and when it falls into the peritoneal cavity, so here's our organ now, it is going to be covered with now a visceral peritoneum, correct? And so the mesentery is that structure that now is keeping it suspended within that peritoneal cavity. So that's actually what mesentery is. Our organs came into the cavity, took the parietal peritoneum, made it become its visceral peritoneum, and now the connection between it and the parietal peritoneum is now mesentery, and it's indeed 2 layers.
Could that be almost like a polyps?
Like a polyp? No, because a polyp is attached by a stalk. So this is a serosal membrane applied to another serosal membrane. So a polyp actually has connective tissue. Okay. So this is important because this mesentery is going to hold organs in place and obviously is going to contain blood vessels, nerves, and lymphatics going to the organs. For the most part, it is attached to the posterior abdominal wall. But we have other mesentery that makes up the greater omentum of the stomach, the lesser omentum of the stomach, as well as the falciform ligament. And those are all mesenteries. And so we have the liver being suspended from our diaphragm and also our anterior abdominal wall. So we have that falciform ligament with the ligamentum teres, or what's the other name for it? The round ligament in the inferior aspect of that. And those are all structures you're supposed to be able to identify even on your cat. Let's take a look at the cadaveric picture here. Okay, so we have here, this is the D for diaphragm. This is definitely the S for the stomach. This is the L for the liver. And we see the falciform ligament anteriorly and the round ligament as at the inferior margin of that falciform ligament. The stomach has 2 curves. It has an outside curve and an inside curve. The outside curve is really big, and it's called the greater curvature. The inside curve is really small. It's called the lesser curvature, and attached to both is omentum. And they call the greater curvature omentum the greater omentum, and they call the lesser curvature omentum the lesser omentum. And so here is our GO, greater omentum, and it's huge. It's a huge apron, and those of you that have already been in dissecting the cat saw how huge it was. It is attached to the greater curvature of the stomach and is just like a darn big old apron that lays over all of your abdominal contents, and that's where it's supposed to lay. Now, the greater omentum in the human and the cat is very different in the aspect that the human has tons more fat in the greater omentum, and that's because we have a high-calorie diet, so we have a lot of intra-abdominal fat. Now, your cats who were well-fed will have a lot of fatty ribbons through their greater omentum, and those that were not so well-fed will have fat, but it's going to be skinny little fat that's in its greater omentum. So this greater omentum is very vascular. It's like a little warming blanket or electric blanket and full of nutritional reserves, which is what our fat basically is. Now, on the lesser curvature between the liver and the stomach is the lesser omentum, and that's where you guys are dissecting out to find your biliary tree. And so you have to go in between the stomach and the liver to finish out your dissection work to also discover the various aspects of the biliary tree. We have reflected the greater omentum cephalad or superiorly. So here's GO, greater omentum now. And now we see it is attached also in us to our transverse colon. The transverse colon traverses our abdomen. It is actually a really big petulant structure, which means it droops on down. It's much longer than what you would expect, and also has the greater omentum attached to it. However, it has its own, in us, mesentery, that is the mesocolon here, that is attached to the posterior abdominal wall that is actually responsible for keeping it in place. So that greater omentum from the stomach does not do that. Take a look at what we typically think of when I say mesentery, and your experience with the cat brings you to what's called mesentery proper. So this is the mesentery of the small intestine. Take a look at that picture, and how does that compare to the mesentery in your cats? It's got a lot more fat there. You cannot see through it. In your cats, you can see through the mesentery of your cats. In the human, you will never see through the mesentery of your cats unless you're going into an area where there's a lot of starvation actually occurring. So another area that we actually store intra-abdominal fat. Is intra-abdominal fat really good for you?
No.
No, it's actually very bad for you and your health. And so one of the things that you have to realize, this is the way we are. This is a societal thing, and we can actually live without all this fat intra-abdominally, but then we are actually more dependent upon making sure we get nutrition from our environment that's going to sustain us. But we have lots of fat reserves internally as well as externally. Now, blood supply. This is what I want from you. I want a knee-jerk reaction. Like when I say, what's the most common cartilage in your body, you all know to say, hyaline cartilage. When you hear the word splanchnic circulation, think arterial gut. Okay, so splanchnic circulation is the arterial side of blood supply to our gastrointestinal tract and related organs. Hepatic portal circulation is a redundant phrase, because outside of our class, it will not be called hepatic portal, it will be called portal circulation. So we're being redundant with this term hepatic. And this is venous. And again, gut. And more specifically, from the gut that just absorbed the nutrients from your meal. And so that's all down the small intestine, stomach, small intestine, and even large intestine. So hepatic portal is taking venous blood to the liver. This venous blood is nutrient rich, and it's going to the liver for processing, because we don't ingest only nutrients. In our society, we ingest other things for pleasure, I guess. But we ingest alcohol, drugs, we ingest aspirin or Tylenol or ibuprofen. All of that material is going to go to the liver so it can detoxify our poisons and then repackage the nutrients that can be then moved around in the circulation for our cells to actually feed off of. And so the liver is very vital in this, and our blood will first go to it for processing, and then from the liver it will go through little hepatic veins right into the inferior vena cava. And so with your cats, you should be able to appreciate your cat's liver is literally sitting on your IVC of the cat. And so, or post cava is also another name for that. So the liver is truly going to put processed venous blood into the IVC, which goes into what part of the heart? It goes into the right atrium, and so that's when that blood has been processed. Once it goes into the IVC back there and then goes into the right atrium, because then that's going to go to the lungs, isn't it? And in the lungs, it's going to get oxygenated, and then from the lungs, it's going to go to the left side of the heart to then feed us. So we put in the nutrients right before it goes to the lungs, and then in the lungs we add the other gas that we need, and then we feed our cells after that. Let's take a look now at the histology of the digestive tract. and realize there are 4 basic tunics to the GI tract wall. We will find variations in their construction based upon where we are in the digestive tract because things will differ based upon where we are in the digestive tract. We will have mucosa, we will have submucosa, we will have muscularis externa. So we're going to add externa because there is a muscularis mucosae. So that means that there is a little muscular layer associated with the mucosa, which is very different than what we've seen before. And then we'll have the outermost layer, which is the serosa, which is, again, it's going to be visceral peritoneum if it's suspended in the cavity. And this is just showing you 2 here. Reinforcing vein, artery, and lymphatic vessels are found typically within our mesentery. Let's go down into the notes and we'll take a look at some of the arrangements or the functions that we're going to find based on the arrangements. The motility will come from our muscularis externa. And based upon where we are, we will have peristalsis, or what the function is, as well as mixing, which is also referred to as segmentation. In peristalsis, we want to move things in one direction, so what we will do is we will relax things up front and we will contract things behind in order to move it along. Once it's moved in one area, then we'll continue the relaxation as it's moving on down and continue our contraction wave also as it's moving on down. Bolus. Bolus is a very common term that will be used by me as well as in the medical field. Bolus is a large volume given at once. Have you ever heard of an IV fluid bolus? What they're doing is they're opening up the IV line and they're letting a large volume of fluid into that individual all at once. And so that's what a bolus is, even when we're talking about food. Our definitions here of mucosa: an epithelial membrane that lines the GI tract, and it's going to have a epithelium, it's going to have CT, and it's going to have this muscularis mucosae, which is what type of muscle? Smooth muscle. So we're in the GI tract, so it's all smooth muscle once you get into the stomach. So we'll talk a little bit about the esophagus construction. It's a little bit different with that in just a moment. But based upon what the function is in the area, our mucosa can have a secretory function, and the secretory function could be acid. That means we're in the stomach, correct? It could be hormones. We'll talk about that when we get into that area. It can be enzymes, and it could be mucus. So based upon where we are. Absorption, well, we're going to absorb the digestive materials that have been properly chemically digested. And so what we'll find with the mucosa, we will find in areas of absorption, we will find modifications to increase surface area. So we'll find villi and microvilli. And then protection. We need to be protected against acid seeping in between our cells and infectious agents. So we'll have nice tight junctions in between the cells so that we don't have things leaking in between the cells getting into then the connective tissue area. for the most part of our digestive tract, the cells that we will find are simple columnar cells with lots of goblets. But what about the oral cavity? Is it simple columnar in the oral cavity? No, that's stratified squamous epithelium. So again, this is a generalization, but you know in the oral cavity that's stratified squamous epithelium. And what about your esophagus? Do you think the esophagus has to be toughened up a bit? And so we'll find still stratified squamous epithelium also in the esophagus. But once we get into the stomach, it's going to be simple columnar. Let's see here. Lamina propria, that is going to be CT, and this is loose CT. And it's just going to be right below the epithelium. Keeping it attached to the surface of the underlying structures. And then muscularis mucosae. This is a really tiny layer of smooth muscle. So thin layer of smooth muscle designed to provide local movements of the mucosa. Well, that's kind of strange when you first think about it, but what it is, it's a thin muscular layer underneath this mucosal membrane, so to speak, and it helps to actually cause a little bit of what I call almost microscopic shimming and shaking. So if your food material that needs digestion, that is a little bit more chemical to allow it to go into the cells, what's really interesting is we have digestive enzymes also on the surface of our cells as part of their membrane. And so when food material comes into contact with it, in order to mix it around a little bit, we do a little bit of shaking and shimming. And so this process will help us with further digestion as well as allowing the material to get closer to the cell membrane and actually into the cell. So it's an interesting process this muscularis mucosa does. It's not something that you would see grossly with the naked eye. You'd have to look at it at the microscopic level. Then we have mucosa. It is areolar plus dense irregular connective tissue that's right below it. There's not too much in it most of the time, and it is designed to actually contain BVs, blood vessels, nerves, and lymphatic. The other thing too, based upon where you are, sometimes you'll have lymphatic nodules. And that's a feature that we talked about previously as Peyer's patches. And that was in our ileum. So that's where we find those Peyer's patches themselves. Then, as we're going out, we have our muscularis externa, smooth muscle responsible for segmentation, which is a mixing process, as well as peristalsis. And we have a longitudinal layer, which is external, and a circular layer, which is internal or deeper. There is a nerve plexus called the myenteric. So myo, which is muscle, and that was kind of, the O was dropped for the enteric, which is intestinal. So myenteric nerve plexus. So is that voluntary or involuntary control? involuntary control, and predominantly from the parasympathetic nervous system, because rest, digest. So the myenteric nerve plexus is going to be responsible for normal gastric motility and action whenever we eat. Serosa, visceral peritoneum covering intra-abdominal pelvic organs. So that's important to realize. It has to be within the abdominal pelvic cavity. There is an exception, and this exception is kind of obvious because it's actually not in the abdominal pelvic cavity. That's our esophagus. That one is covered with adventitia. Adventitia also covers our trachea and the bronchial tree before it actually goes into the lungs, so it's a primary bronchus. Adventitia is different from serosa. Serosa is like saran wrap, really helps to keep things applied and in place. Adventitia has more laxity associated with this and is another reason why people who get esophageal cancers get rapid spread, because it's not actually pegged in place by the serosa, and it can actually invade and travel quite far. Dual regulation of digestive processes. We talked about how our normal physiology, we have the nervous system to get an immediate response, and then we have the hormonal system to take care of background processes for us. Same thing here. We have the nervous system, which is an ANS, and predominantly parasympathetic aspect of the nervous system, and we have also hormonal control of our various digestive processes. On the nervous system side, we have baroreceptors and chemoreceptors, and they will then create a response based upon what they are experiencing. Baro is pressure, and so baroreceptors detect local stretch or pressure, and so when you put some food inside the stomach, that stretches it and will send information to the brain via parasympathetic routes to actually promote increased acid secretion and production of gastric juices. Chemoreceptors are going to detect the presence of very specific substances in the lumen. And so whenever we have an acid dump into our small intestine, we have chemoreceptors there that will actually send a signal back to decrease acid production itself. And also when we experience fatty acids or other lipids in various areas, those chemoreceptors will be able to detect and send information to where we then also will have an impact on the amount of whatever juices are being actually delivered in the area of the stomach, for example. Hormonal. We have three hormones that I would like you to know about that are associated with the gastrointestinal tract: gastrin, secretin, and cholecystokinin. Cholecystokinin is often abbreviated CCK, cholecystokinin. Let's go ahead, since I'm on cholecystokinin. It is released from the small intestine as well as secretin is. Both of these will impact gastric juice production. It will cause it to decrease, and also will cause an increase in bile release and pancreatic juices. So secretin and cholecystokinin both will do that. It will decrease gastric juice, which is a bunch of juice released by the stomach to the contents of the stomach. It will increase bile and pancreatic juice release. The thing that is the strongest of the two is cholecystokinin. So that one's stronger than secretin. Gastrin is a hormone released by the stomach that is designed to increase gastric juice production. So we have hormonal regulation of what our stomach and small intestine is doing, as well as ANS nervous regulation. Now let's take a look at some of the structures associated with the gastrointestinal tract. Mouth, also known as oral or buccal cavity. Buccal is the cheeks. Lips and cheeks contain a core of muscle and an epithelial membrane covering. And so remember, epithelial membrane is epithelium plus the CT that keeps it attached, which is also known as lamina propria. And for this is stratified squamous epithelium. The core of muscle, is that smooth or skeletal? Skeletal, because we have voluntary control of that muscle. So anything that you have voluntary control of, you have to realize is skeletal muscle. Those are the things that are very much involved in ingestion. The palate, which is the roof of the mouth, has two components. We have a hard palate and a soft palate. Hard palate's anterior, soft palate's posterior. Hard palate's made up of two bones, the maxillary bone and the palatine bone, with the maxillary bone as the largest of the two contributors to the hard palate. Posterior to that is our soft palate, and it is mostly skeletal muscle. It is going to close off the nasopharynx when we swallow. So if you had dysfunction, in other words, the soft palate didn't work properly and you swallowed something, what could possibly happen? Especially if it's milk. It can shoot out your nose, absolutely. So it's nice to have a soft palate that's properly functioning. So it closes off that nasopharynx, which is kind of like what the epiglottis does to our glottic opening or our larynx, trachea. The tongue is an interesting organ. What is it covered with? Stratified squamous epithelium, right? Everything in the oral cavity, anything that's going to come into contact and be traumatized, right? We want to cover it with stratified squamous epithelium. So the tongue itself is covered with stratified squamous epithelium, but its muscles are voluntary, correct? So it is skeletal muscle. And it's an interesting combination of skeletal muscles that we actually have here. For the tongue itself, for the actual tongue, not what the tongue always does, but for the actual tongue, it is made up of interlacing bands of skeletal muscle. And so we have these muscles of the tongue called intrinsic muscles. Which are the interlacing bands of skeletal muscles that controls the shape of the tongue. And the interlacing pattern allows you to do certain things. And not everybody can do this, which means that their muscular pattern of their tongue is different than yours. Because most of us can roll the edges of our tongue. There are some people that cannot do that. So that is an indication that their interlacing pattern of muscles of their tongue is different than yours. So that's the intrinsic muscles of the tongue. The extrinsic controls the movement of the tongue. In other words, when you stick your tongue out, the reason you were able to stick your tongue out is you used other muscles that are attached to the undersurface of the tongue. Those are the extrinsic muscles of the tongue, and so they don't have that interlacing pattern associated with them. So sticking your tongue out is an extrinsic action, and what the tongue looks like when you stick it out was the intrinsic muscle action that you actually see. The tongue is also going to be very important because it will mix the food with saliva to form the bolus. So let's take a look at salivary glands, which produce saliva. And you know, saliva is mostly water, but we do have some other things in saliva. We have lysozyme, which is a digestive enzyme. We have amylase, and you know that's an enzyme because it ends in ase, and it's going to actually cut carbohydrates down into disaccharides. So amylase is going to start a little bit of our carbohydrate digestion in the oral cavity, and it really depends upon how much amylase comes into contact with the carbohydrates in the oral cavity. So if you take a saltine, a salty cracker, and you put it in your mouth and you let it stay there for a while, it will start to taste sweet because our taste bud receptors are for disaccharides. We can't appreciate the sweetness of a carbohydrate until it becomes a disaccharide. And so that's what amylase does for us. Mucin, that sounds like that lovely thick stuff that you sometimes have to clear out of your throat and stuff along that line. And indeed, it is really thick, and when mixed with water, makes a slimy layer for us. And then IgA, you guys should recognize that, yes? It's on the upcoming exam. And IgA is made up of how many monomers? The monomers are, what do we call a monomer of immunoglobulins? What does it look like? It looks like a Y. So how many monomers make up IgA? 2. So IgA is a dimer, correct? And so where we have the handles of the Y's coming together and the two prongs off of the Y's sticking out off to the side, so it's actually able to interact with 4 antigenic determinants, because each one interacts with an antigenic determinant. The interesting thing about saliva, we actually produce 1 to 1.5 liters a day. So that's a fair amount of saliva. And it comes from 3 salivary glands. And these are the 3 glands that you were supposed to see if you could identify on your cats. It comes from the parotid salivary gland, which is always associated with our ear and the angle of our mandible. So parotid is right in front of your ear and is overlying the angle of your mandible. Then we have the submandibular. And the submandibular are actually not too difficult to find. All you have to do is go along the edge of your mandible, go from the angle, anteriorly along the edge, and then softly push back and forth, and you'll find a little lump in there. That's your submandibular salivary gland. That's the one that, as we age, gets a little lax and makes us look jowly. And so it will drop on down and give you a jowly appearance. It's not just your skin that's making you look jowly, it's your submandibular salivary gland. If you go a little bit more anteriorly, more under the tongue, you will find the sublingual salivary glands. Of these, the submandibular produces the bulk of our saliva. And the material that it produces is a serous and mucus material. Also, our sublingual is mixed. It produces serous and mucus saliva. So serous is watery and mucus is more thicker or viscous in its quality. So submandibular and sublingual both produce serous and mucus saliva, and so they're mixed. And our parotid produces watery saliva only, so it's serous. And when you take a look at a histology view of this, you can see a nice little thing off here in the corner, and it looks like it's cuboidal cells. It looks almost stratified cuboidal to me, and that is indeed a duct, because you can see right in the middle of it the lumen. The other thing, as I take a look at this, and I want you to appreciate, the mucus cells are pale in their coloration, correct? So mucus cells are very pale in their coloration whenever they are stained. And then serous cells are definitely purplish when we take a look, and even can overlap a mucus cell. And when they overlap a mucus cell, we call them serous demilunes, because they look like half moons. So serous demilunes, here's a beautiful example of a little bit of a moon shape to me. That's the serous demilune, and then here is the mucus component of this mixed salivary gland. Moving on in, let's talk about the teeth. Humans have two sets, and we call our teeth dentitions. And so when you have false teeth, those are dentures. And that's also where dentine gum got its name, because somebody did a little bit of research and found out that dentitions and give a gum a name dentine, and it's meant to be chewed by your teeth, worked out very well for a long time. We have two sets, and the first set is our deciduous, and our final set is our permanent. The deciduous teeth are also referred to as your baby teeth, so those are the first things to come in, but they're called deciduous because they are meant to fall out, be dropped off. And our permanent teeth are meant to be our final set, and we have nothing to replace them, and also are referred to as adult teeth. So let's see. You have a 20 by age 24 months for your deciduous or baby teeth. That's the most common number. Permanent teeth, you typically will have 32 by age 18 years. So you obviously have more, and your mouth is obviously bigger and can handle the larger load, so to speak. There's always some variation. Nobody fits everything perfect, but this is a generalization that you can actually use. Of our teeth, we have 4 categories based upon their shape and therefore what they can do for us. Our front teeth are our incisors. And when you take a look at them, they have flat, cutting edges. And so indeed they are designed for that cutting action, biting into the apple, for example. Canines are lateral to them. These guys are pointed, and they are designed for piercing and tearing. As we go posteriorly, we'll come across our premolars, often referred to as bicuspids. And so they have a surface that is designed for grinding and crushing. So 2 cusps. And then we have most posteriorly the largest, which are our molars, and they are best for grinding and crushing. When we take a look at the structure of the tooth, there's not too many parts to it, but the parts that we have are very important for proper dentition functioning. The outermost aspect that we see is the enamel, toughest substance in our body, and covers the crown. Of our tooth. Then the part that we don't see is the root, and this is under the gingiva. And whenever the gingiva is inflamed, that's a condition called gingivitis, which will lead to tooth loss if not taken care of. Then as we move in and take a look at the area around the root, we find a material called cementum, which is interesting. It's calcified connective tissue that is going to connect the root of the tooth to the periodontal ligament. So periodontal ligament is external to our tooth, and dentin is part of our tooth. So cementum is between the dentin and the periodontal ligament and calcified. Dentin, our notes state, indeed, it's the bulk of the tooth. So all of this right here, this brown material is the dentin. And so we have the enamel covering the exposed dentin, and we have cementum around our dentin that's actually part of the root. Inside, we have an area called the pulp cavity, and pulp is loose connective tissue, blood vessels, and nerves. And we have this nice little area at the base of the pulp cavity where we have an opening where the roots and blood vessels or nerves will actually go into there and feed the tooth. And so we all know, indeed, that the tooth is alive because it can hurt whenever there's a problem with it. What happens if somebody gets their tooth knocked out? What is it that you want to do right away? You want it back in, right? Unless you want a hole, a gaping hole in your smile, correct? If you have a tooth knocked out, you want to go off to the dentist right away and take the tooth with you. If you get a finger cut off, you typically try and grab the finger and put it on ice and take it with you to the emergency room because you'd like it put back on if at all possible. It is possible for us to put our body parts back on in some areas if we have a good enough blood supply, correct? If we have not allowed necrosis or tissue death to occur too long. And the same thing is interesting about the tooth. If it gets knocked out and you go right away to a dentist, they'll clean it up and they'll put it right back in the hole. And if not too much time has passed and not too much destruction of the connections down here has actually occurred, it will reconnect. If it reconnects, you know it because it will have a color that is acceptable. If it doesn't reconnect, do you know what color the tooth will turn? It's black. And so that means that it did not connect. We do not have the good vascular supply, and it's literally a dead tooth in its socket. And do you guys remember, as far as joints go, if this was a synanthi or diarthrosis? Synarthrosis is not meant to move. And do you also remember it's called a gomphosis, which is a peg and socket joint. So keep those little things also in mind for you on that. Pharynx, we're moving on back. Skeletal muscle in its wall helps to propel food downward because our soft palate is blocking it from going upwards. Esophagus, known as the food tube. It's going to pass through a hole in the diaphragm called the esophageal hiatus. It connects to it is going to connect to the stomach on the other side of the diaphragm. And when it's not in use, it is collapsed. Think of the esophagus of your cats. When you found it, did you think it was going to look like that? This flattened, squashed thing? You know, and it's actually, for the most part, a lot of skeletal muscle, but actually a lot of smooth muscle. And if you were to guess, which is up top more superiorly? Skeletal muscle, and as you get closer to the stomach, it transitions into smooth muscle, which is an interesting thing. This food tube starts off skeletal muscle at the top, becomes a mixture of skeletal and smooth in the middle, and finally ends up being smooth muscle right before we actually get to the stomach. At the stomach, we have the muscle that's around the lower aspect of the esophagus called the gastroesophageal sphincter. We say it acts as a valve to prevent reflux, but it is a circular arrangement of these muscle fibers that'll go around and actually squeeze on down that opening. It is one of our weakest sphincters. And we know this because what's a common condition in our society? Acid reflux. And so that sphincter is there, but it's not a really strong sphincter. It's a weak sphincter. And substances that we ingest, such as chocolate, can actually make the sphincter relax. So certain foodstuffs actually make the sphincter not so good at doing its job. And so we all have, I don't know about you, but I have a fondness for chocolate in my life. So it is something that can actually increase a little bit of heartburn or reflux for you. Now, the hiatus that I was talking about in the diaphragm, that means it's a hole in the diaphragm specifically designed for the esophagus to go through. And it should be what size? Small, medium, large? Yeah, it should be big enough for a bolus of food to go through, correct? So be relatively small. Well, what if it becomes big? What will you have if you have the hiatus in the diaphragm enlarged? You have a hiatal hernia. What is herniating through that hole? Is it the esophagus into the lower aspect? No, it's the stomach up into the upper aspect. And so the stomach's not supposed to be superior to the diaphragm, correct? It's always supposed to be inferior to the diaphragm. And so a hiatal hernia is saying that this area in the diaphragm, this hole, has been unfortunately stretched and allowed the stomach to actually pop up into that area, which typically makes reflux a little bit worse for you in that aspect. The muscle, upper 1/3 is skeletal, middle 1/3 skeletal plus smooth, and then lower 1/3 is smooth. We do have longitudinal and circular arrangement of the muscle fibers. So far, the digestive processes that we actually can experience in the mouth, the pharynx, and the esophagus. Mastication is chewing, but you don't need to have teeth to masticate, correct? You can use your tongue up against the hard palate, but that's what we typically refer to as chewing. This is designed to mix food with saliva. This is important because it makes it easier to pass that bolus into the pharynx and down the esophagus into the stomach. Deglutition is the technical term for swallowing. We originate that into the back of the oral pharynx and then on down. Peristalsis is a process that only occurs so far in the esophagus, and indeed we'll be using our longitudinal and circular smooth muscles to literally shorten and constrict and squeeze the food down the esophagus, whether we're standing on our head or standing upright. And now we come to that lovely organ, the stomach. We're now finally in the abdominal pelvic cavity below the diaphragm. The stomach is designed to break down the bolus of food into chyme. It is not designed for absorption. It is to break it down into this pasty material of foodstuffs and gastric juices. Little babies often burp up the material that chyme actually really looks like. So if they're being breastfed and they burp up, it looks like a kind of slimy cottage cheese mixture. And that's what chyme looks like, a real weird, slimy, cottage cheesy mixture. full of acid. And chyme is very acidic. And that's because the stomach is going to dump a bunch of acid onto the foodstuff to help with breaking it down chemically, as well as it's going to move things around in a churning fashion mechanically. Anatomically, when you open the stomach, if it is empty, you will see rugae. So rugae are folds in the mucosa of the stomach wall. If it's full, do you see rugae? No. And so empty stomachs will have rugae, full stomachs will not have rugae. We have an area of the stomach called the cardiac region. So right there where the gastroesophageal sphincter is, when we go on the other side, here is our cardiac region. It's a small area where the esophagus plugs in and just is the immediate stomach region. So that's the cardia. Then we have an upward bulge called the fundus. And it's right underneath the diaphragm. And so it's easy to actually see where the fundus of the stomach is if you get a plain upright x-ray of somebody, because it always has air in that area of the stomach. So fundus, superior to the cardia, under diaphragm. The body is the bulk of the stomach, so it's the main part of the stomach. And then we have a pyloric region, which is where the stomach starts to narrow down. We'll actually have a narrowing down in that pyloric region, and that is the end of the stomach, which will terminate in the pyloric sphincter, and on the other side will be the beginning of the small intestine or the duodenum. This histology here is easy to figure out because you guys know what this stuff is, right? Stratified squamous epithelium. So therefore, if this is stratified squamous epithelium and we're in the digestive tract and we have this sudden transition or change, we are at the gastroesophageal junction. And so we have a big transition here. We go from stratified squamous epithelium to that simple columnar epithelium once we hit the stomach. And so you can easily actually, from a slide that has both, you can figure out where you actually are. You're in the cardiac region of the stomach based upon this side. And so there's going to be columnar cells, simple columnar cells, that are actually going to give rise to these things called gastric pits. We'll talk about that in just a second. One of the things I do want to mention, again, here is, so your stomach is going down, and it's a C underneath your diaphragm to your left. Your liver is off, for the most part, to your right. The left lobe of the liver is actually a pretty small lobe that's adjacent to the stomach, but your stomach is over here on your left side, and your liver is going to be taking up most of the right side underneath your costal area of your ribs. And the stomach is got its greater curvature off to the outer aspect, and its lesser curvature is facing the liver. The greater curvature has the greater omentum attached to it. The lesser curvature has the lesser omentum attached to it. When we take a look at the tunics of the stomach, or remember tunics are layers or coats, we see that our muscularis externa is not just 2, but it's 3 smooth muscle layers. We have the circular, which is what we know to expect. We have the longitudinal, which is what we expect, but we have the third layer, which is oblique. And so this additional layer allows the stomach to actually function more effectively as a churning organ. And the churning is designed to break the foodstuffs mechanically into smaller material to help us with the chyme. The mucosa is indeed the columnar epithelium and is entirely, listen to this, entirely goblet cells. Where do we find goblet cells? Always with columnar, simple columnar epithelium. Even if it's pseudostratified, isn't that pseudostratified still columnar? We call it pseudostratified because it looks stratified, but it isn't. It's simple columnar. So we find goblet cells with simple columnar epithelium. And I'm telling you, the entire lining of the stomach is goblet cells. And this is an interesting thing because these goblet cells secrete a mucus that is alkaline. And why is that alkaline mucus so important? Because the stomach secretes acid into its lumen. So if you're putting a bunch of acid into your lumen and you don't want to eat it away at your lining, it's not a bad idea to actually have a mucoid layer that is alkaline to protect the cells underneath this acid that's inside the lumen. So this alkaline mucus is very protective. And if you have a defect in the cells secreting alkaline mucus, what do you suppose could happen? Ulcers. So this is a very important function for protection of the stomach's function itself, which is to produce this acidic juice or gastric juice. Also, when we take a look at the mucosa, if we were to take a little bit of a handheld magnifier, open up the stomach like you guys have done, and take a nice good dissecting microscope or handheld magnifier, you would actually see all these little dots, these little pits or divots all over the lining of the stomach. And they are called gastric pits, and they lead to gastric glands. So you see these dimples all over, and those dimples are actually pits. You know, if you dug a pit, you know, it would take you on down deeper into the earth, so to speak. And that's what this is doing. It's taking you deeper into the stomach's wall. And in the pits still, we have mucus cells lining the pits. And then as we go deeper on into these gastric glands now, we will find parietal cells. So parietal cells, chief cells, and the enteroendocrine cells are actually in the glands. There's still a few mucus cells, but the mucus is on the surface, it's in the pit, and then once we get into the glands, we'll find these interesting parietal cells, chief cells, and enteroendocrine G cells. The parietal cells are the cells responsible for producing the hydrochloric acid. They also produce this thing called intrinsic factor, which is absolutely necessary for oral absorption of vitamin B12. So intrinsic factor and hydrochloric acid are produced by our parietal cells. And B12 is absolutely necessary for appropriate red blood cell production. B12 is absorbed in the small intestine, more specifically in the ileum. Oops. Yeah. Chief cells, also referred to as zymogenic cells, you're going to have to memorize that one. That's actually in the literature a lot, produces an enzyme called pepsin, which is a protein digesting enzyme. Acid will digest away at proteins, because remember we degrade our proteins with acids, and also the pepsin will do that. Protein digestion. Pepsin is most active in an acid pH. We'll stop there. You guys did really good for such a quiet group.